Here they are taking a break from Eurocup, by the way. We're taping this today. Today is June 21st, and the Netherlands just scored a goal on France, but then it was reversed. So it's still 0-0. By the time this airs, we probably actually, let me tell you when this will air. Before we make the introductions, this will air on July 9. So we still do not know who is going to be the champion, but we know it's not going to be Hungary. So
don't rule that out. There's still a statistical chance.
Is there really?
There is. The p-value is sort of.
I go by hazard ratios. I stopped doing like p-values. We're going to start with intros, but we're going to start with Lecia, Dr. Sequist. Please, a lot of people know you. And if, by the way, even if there's like a couple of people who did not know you, after this last ASCO 2024, everybody knows you right now. So tell us a little bit about you.
Thanks, Chadi. I'm Lecia Sequist. I'm a medical oncologist. I focus on lung cancer, and more recently, my interest is in early detection and screening. I practice at Mass General in Boston, and we're celebrating here because our basketball team just became the world champions. Very, very happy. We had a big parade just today, and all is well.
Yeah, parade today. And Balazs, I will never understand why they became the world champions, because they're the US champions, right? I mean, they're not the world. I mean, there's a world outside of the US, Balazs, like Hungary. I mean, they're not the champions in Hungary.
Exactly. Did they beat the Hungarian basketball team?
Exactly right. So I'm not sure what's this idea, but with that, Dr. Halmos, tell us a little about you.
I'm Balazs Halmos. I'm not missing Euro 24 at this point because my team is practically out. That's very true. I'm a medical oncologist at Montefiore in New York, and I oversee the thoracic team and the clinical trials office here, and look forward to our conversations.
The early detection is like a completely different podcast. I need to do one like that. But okay, well, look, lung cancer was honestly the talk of the town in Chicago. Let's face it. I think it stole all of the lights and everything, deservingly so. I don't know how many practice-changing ones, but Lecia, you took center stage as a discussant for a very important abstract. So I'll let you both decide in the plenary, but I'll let you decide how you want to start. We start from plenary and go down, or we start from down going up to plenary. Hey, you're on the show, and we start with you, Lecia. Which one should we talk about?
Well, hey, let's talk about Laura first.
All right, let's talk about Laura.
So Laura was a very anticipated trial because when we think about our EGFR lung cancer patients, we have an indication to use EGFR TKIs in almost all stages of disease, except up until ASCO. We didn't really have data-driven recommendations for patients with stage 3 unresectable EGFR lung cancer. So Laura was the first big randomized trial to be done in that specific disease stage for EGFR patients. And the design of the trial was that patients with EGFR exon 19 deletion and L858R who were deemed to be unresectable were treated with the standard chemotherapy and radiation. But then after that was over, they were randomized to receive either osimertinib or placebo. And the primary outcome was progression-free survival. So I think the two key things to note about the design is that it was placebo-controlled, not durvalumab-controlled. So some may argue that after the Pacific trial, durvalumab was the standard, and we can talk about that. But then the other interesting design aspect was that the duration of the osimertinib or placebo treatment was just ad infinitum until progression. There was no defined course of 2 or 3 years.
So, Balazs, is it fair not to put Durva as a control?
Yeah, great starting point. And I think it was very, very fair. Looking back, it was very fortunate that they didn't design it that way, because the Pacific study ultimately had sort of a post-hoc analysis looking at patients with EGFR-mutated disease. As expected, it didn't show any real benefit, of durvalumab in that context. I think we all know by today that, giving immunotherapy before somebody needs an EGFR TKI can actually be a concern as to added toxicity. So I think in a way this was the better and safer design, comparing osimertinib with placebo as opposed to a non-active but potentially toxic and expensive drug. And the study is super positive. Of course, there could be some criticisms. I think the major criticism is that patients were not mandated to get PET scans. And we hear that maybe about half of them did, but let's admit that in the 21st century, locally advanced lung cancer, 100% of the patients should have received a PET scan prior. So it's a bit of a criticism. I think the patients were slightly understaged, and maybe that explains that in the placebo arm, a whopping 87% or so had progression within the first 2 years. So these patients practically have metastatic disease at the outset, micrometastatic disease. But maybe with PET scans, that group could have done a little bit better, not much better. The separation of the curves is humongous. As you've seen in pictures, people were able to put fire trucks, giraffes, whatever you want to do in between the survival curves. Will that translate into an
survival curves
benefit?
Survival curves?
Progression-free survival curves. Now, the overall survival is early readout. There's some trends towards separation. I think the crossover in this study was very good. 80% or so of patients in the placebo arm received osimertinib upon progression. So that limits a little bit the ability to see a drastic difference, but I think we will still see it. So I do trust it will be a positive study. And in terms of the indefinite duration, maybe that's not so much of a concern as from the ADAURA study, we kind of learned that maybe 3 years is not sufficient to begin with. So I think that was a good decision, again, on the study team's part. So an excellent study, transformational results globally, but in reality confirming the practices of many U.S. oncologists, as many of us had already been using this as our standard of care for a while.
Lecia, let's talk about the staging a little bit. Since Balazs talked about this, I mean, as a discussant, tell us how you approach this, because without having the PET scan, obviously in staging, how much would this confound the results? Is there any statistical way to figure out how would the results might have been impacted?
Yeah, so I mean, I think it was a pragmatic design because in this trial, the patients were screened and randomized after the chemoradiation. So they weren't captured at the time of diagnosis when you could maybe mandate that everybody have the exact same baseline studies. And this was done in a global setting, and I think really almost extensively outside of the US. And there were several countries in South America, China, Russia. So, I don't think that PET scans were necessarily available in all of the study locations. So in some ways, it is very pragmatic. It is much more generalizable. I will say that we just recently, before ASCO, had published a small study from Mass General and Dana-Farber where we were looking at stage 3 EGFR lung cancer patients. And this was a prospective study. Everyone on that trial had not only a PET scan, but also mediastinal staging before they were declared to be stage 3. And once we started the TKI, the design of this trial, the ASCENT trial, it started with induction TKI and then went on to chemoradiation. And the TKI was afatinib because the study was started, over 10 years ago. But the point being that even with PET scan and invasive mediastinal staging in, a tertiary care center, we still had some patients who, once we started the TKI, lo and behold, they actually had stage 4 disease because we could suddenly appreciate bone mets. So, I think that the biology of EGFR lung cancer actually may tend towards early metastases, some of which are not clinically apparent, some of which are too small to be picked up on PET scan, even if it's performed. So I think that you can critique, certainly, that everyone in the study didn't have the exact same staging analysis, but I think it probably is true that EGFR cancer is a little bit earlier to metastasize maybe than a wild type.
So just to piggyback on this, Lecia, the randomization happened after patients complete. So they did not consent in the beginning. So in other words, you had the option after you finish the definitive chemotherapy and radiation.
To enter the trial, yes.
Yeah, was there uniformity in terms of the chemotherapy given, the, I don't know, radiotherapy technique? I presume the dose is the same with RT. I'm just trying to, is there any impact into that?
Yeah, so they did have minimal, criteria to increase the standardization. But, I will say this is the same design that the Pacific trial employed, where the patients were not approached and consented at the start of, at the time of diagnosis on Pacific either. It was also after the chemo radiation. So, and that has certainly become the new standard of care. So there were some parameters about radiation. It had to be 60 gray of radiation with a window of plus or minus 10%. The patients were allowed to have either concurrent or sequential chemoradiation, which, sequential has it's been over 20 years that we've known that concurrent chemoradiation is somewhat preferred over sequential, and there were only 22 patients on the entire trial that received sequential, so it was a small number of patients, but it was a real world study.
I'm a big fan of pragmatic studies. I mean, really, I think we can criticize them all we want, but I do think there's value in doing like, look, this is what happens in the real world, and some people get PET scans in the US, but they may not always get PET scans in Brazil or Argentina, so we have to be really very careful with this. But I do have, Balazs, as a non-thoracic oncologist myself, I have a problem with indefinitive therapy for somebody who doesn't have metastatic disease. So I may disagree a little bit with you there. Convince me, why can't we stop treatment after, say, 2 or 3 years?
Well, I think, when you have a conversation with your patient, first of all, they're always in the driver's seat. So they decide actually how long they continue the treatment. So I would break it down into, digestible segments in a way. First, let's just make sure that, you can tolerate the medicine. Then we'll go, scan by scan. But if you think about, again, this biology, and Lecia so nicely stated that these patients have early micrometastatic disease. If you look at the ADAURA study, an earlier stage patient population, right, these patients actually went to surgery. After surgery, were incidentally found to have nodal disease. In the placebo arm of that study, again, 70+% of the patients recurred within just 2 to 3 years. So basically, stage 2-3 EGFR-mutated lung cancer is micrometastatic stage 4. The stage 4 disease in disguise. And the treatment that we're offering is truly not curative, although extremely effective in terms of containing, controlling the disease. So that explains the need for long-term suppressive therapy. And let's admit that our breast cancer colleagues have gotten very much used to this concept, and they have no problem, presenting it to patients and patients accepting having to live with hormonal therapy for very extended period of time, whether that's 5 years, 8 years, 10 years. Indefinite seems like signing on, forever, but let's take a scan by scan, year by year. But yes, indeed, based on the biology and ongoing suppressive treatment in this particular situation actually does make sense. And luckily, that treatment typically is quite well tolerated. So it is something that patients can sustain a very high quality of life.
I like that analogy. I like the analogy of breast cancer. I haven't thought about it, actually. You're right. For breast cancer, hormone positive, women could go on for 10 years, or I don't know the latest data if it's more than 10 years, but certainly 10 years.
Yeah, medicine still needs to improve for treatment to be indefinite. Our lifespan is still limited.
Yeah. All right, so that's Laura. What else, Lecia? Let's take another one. And again, we're focusing on this podcast on this, just breakthroughs, the ones that really kind of, were the talk of the town.
I think we have to go with ADRIATIC.
ADRIATIC. Where do you guys come up with these names? Where do you come up with these names? ADAURA, Laura, ADRIATIC. What is this?
I was actually in a conversation a couple of years ago with our mutual friend Hasbor guy, and he was talking about the Caspian study, that he likes it because he spent his summers, by the beaches of the Caspian Sea. And I told him that I like Adriatic because I spent my childhood, summers on the beaches of the Adriatic Sea.
I'm
So
okay
don't
with
click on
the
Adriatic.
I'm okay with the Pacific, actually. I'll stick with the Pacific since I'm in the US. So Adriatic, let's hear it, Lecia.
Well, the ADRIATIC study was also presented in the plenary session by David Spiegel, and this was a randomized control trial done in small cell lung cancer, limited stage disease. So until this moment, our standard of care has not changed in decades. Chemotherapy, platinum etoposide with concurrent radiation. There's been some changes of practice over the years about what to do after that, maybe prophylactic cranial irradiation, or maybe you can just monitor with MRIs, but the systemic treatment has not changed in a long time. So this study added immune therapy finally into the mix. And patients, after they completed chemotherapy and radiation, were randomized to receive 2 years of durvalumab or placebo. And this trial actually was able to report both the progression-free and the overall survival outcomes. And we saw nice improvements in both measures for the durvalumab arm compared to placebo.
So Balazs, was there, prior to this trial, with the standard of care, just chemo RT, was there no data to add anything to this, right? Or
so immunotherapy has shown benefits in extensive stage small cell lung cancer.
Got it.
So that's been the standard of care for a few years. But admittedly, if you look at the studies, leading to the approval of atezolizumab and durvalumab in extensive stage small cell lung cancer, the benefits are really modest, truly very modest. So in reality, we weren't sure how much benefit we will see in the setting of limited stage small cell lung cancer. So as compared to LAURA, where everybody knew what the LAURA study will show. I mean, a couple of years ago, we could have drawn the survival curves, right, Lecia? And we would have been pretty accurate. With the ADRIATIC study, we went into the plenary session not knowing how good the results will be. And we were very impressed. The fact that you saw an overall survival benefit so early tends to be a very good sign. I mean, this is a massively beneficial treatment in these patients. It has the ratios in the mid 0.7 range, both for PFS as well as OS, finally making a huge impact in the context of limited stage small cell lung cancer. Recognize that the benefits of added chemotherapy to radiation were like 5%, PCI 5%. So we're talking about bigger advances than the previous building blocks in terms of management of limited stage small cell lung cancer had achieved. So this is really a dramatic advance. We spoke about PET scan as my pet peeve with the previous one. Here, let's just talk about that the patients upon progression had a limited chance to receive immunotherapy though. So if you look at the data, I think just about 15% of those patients upon progression received immunotherapy-based regimens. So again, a little bit of a criticism in terms of how the study was designed and conducted. But I don't think that shortcoming mitigates this very, very, very substantial benefit. So in reality, I think it's a slam dunk. It's a practice-changing slam dunk. In reality, the drug is available, so we can implement it as of 2 weeks ago. With that, I have to say that the last domino fell in terms of immunotherapy benefits in lung cancer, stage 4 non-small cell, locally advanced non-small with Pacific, early stage, neoadjuvant, adjuvant, perioperative, extensive stage small cell lung cancer. Now the last piece, limited stage. So anti-PD-1, anti-PD-L1 therapy benefits now the broadest range of patients across the board. And now we need to make sure we implement it, across the globe for all patients who could benefit from it. But also think about now new ways of improving outcomes. There was a very nice editorial, I think, in JCU about let's stop the Me Too's. We have 16 anti-PD-1s, anti-PD-L1s. Those will not yield major advances from here on. We need to refocus on some other avenues.
Lecia, for the ADRIATIC and broadly in small cell lung cancer, is the data giving the IO after you finish chemo RT, or is it part of the chemotherapy regimen? You give it with chemo and then you give it after you finish chemo RT?
For ADRIATIC, it was after. And that, that's really when we're talking about concurrent chemoradiation, that's now our standard for both non-small cell and small cell. Some of the data about trying to move immune therapy earlier has yielded controversial results, or at least results that don't seem to make sense in non-small cell. So yes, the concurrent chemo with IO does not happen during radiation in lung cancer at this time.
Okay. And then can you comment on the percent of folks who received IO upon progression? Because everybody got chemo RT, they were in CR. By PET, I presume you had to do PET for small cell, right? I mean, you cannot tell with small cell if you're in CR unless you do a PET. No?
Again, it's not a standard of care in terms of assessing for response.
No, but in the beginning, to be sure that it's not extensive stage, you must have done a PET.
In the US, yes.
Okay, so
for the study, I can't say that. I don't think the study mandated a PET scan.
This was also a global study. This was also US and Mexico. Okay, got it. Okay, so there's some criticism there. Do we know how many did not receive PET or not? Okay. So
I do not know.
Then you had the for the, I guess you said 15% at the time of progression did not receive IO therapy. It seems or received IO therapy. So 85% did not receive it.
Yeah,
So
it seems like a low number. It's kind of hidden in one of the tables that was presented. That's a little bit of a concern, but I don't think it's a big enough concern in reality to again, mitigate that huge benefit seen.
What's the absolute benefit was like in months or?
So the median overall survival, again, there's Dr. Spiegel actually encouraged us from the podium not to focus on the medians only because the whole length of the curve is more accurately depicted by the hazard ratio. But the difference in the median overall survival was 2 years, which is a clinically a gigantic difference in median survival.
In small cell?
In small cell lung cancer.
You can't argue with that. I mean,
from 33 months to 56 months.
I mean, the 33 months is a lot. I mean, I'd like for people to live forever, but 33 months for a limited stage is pretty, is that pretty expected nowadays? I mean,
we're like curing, patients with limited stage small cell lung cancer, but from now on we'll be curing more. So,
All right. Well, we've got improvement now in small cell and non-small cell. Okay, Lecia, what's next?
I think I have to let Balazs pick what's next. I picked the first.
Balazs, we've gotten more in ADRIATIC. Why don't you pick one?
Well, I mean, the crowning achievement, for me was crowned. Don't you think, Lecia? I mean,
I have to say he's pretty good on these, like, how he on Twitter, he knows how to do these memes and everything. He perfected this.
I cannot bring my memes here, but just a 5-year plus median progression-free survival in metastatic lung cancer. Just if you think back as when we did our fellowship, when the median was a year, and that was for everyone. Everybody did the same way.
Let's talk about that trial, though. Tell us about that trial. That's the crown.
Well, the trial now goes back a couple of years, so all of us are very familiar. This is now comparing sort of the next generation ALK-TKI lorlatinib, with crizotinib, which nobody uses any longer. So if somebody wants to criticize the study today, they can, because that drug no longer is kind of a valid option. But at the time the study was designed, then patients started to accrue, especially thinking about a global study where the new generation ALK-TKIs got approved at a later time. It was appropriate at the time. But looking back now, it can identify the benefit of this new generation of drugs, where the hazard ratio of lorlatinib versus crizotinib as progression-free survival is 0.08. I'm just going to make it up, but it was in that particular range. And again, that median value, more than 5 years of metastatic disease, you're still staying on your first drug. You haven't switched drugs. You're staying on your first drug for more than 5 years. That's 60 refills, right? I mean, 59 refills on your prescription, and the patient is still going, okay? Of course, there's downside. The downsides are a bad side effect profile, but there's also great upsides in terms of fantastic CNS activity. it is just a stunning achievement. I think it just sort of brings home what this field accomplished. You know, it's congratulations to Dr. Solomon, congratulations to the Pfizer team, but it's the field. It's investing into science, biomarker testing, targeted therapies, immunotherapies. This is now, you know, what we achieved as a you know, joint crew across the globe. You know, this is time to celebrate it a little bit, but again, making sure that, you know, all of us around, you know, the globe can benefit from it.
So I love that trial. Lecia, can you comment on this a little bit about this trial and maybe just talk a little bit about the crizotinib as I realize that at the time of design, folks were still using crizotinib to an extent. But I mean, and again, comment on that.
The hazard ratio reflects, you know, the difference between the lorlatinib and the crizotinib, and the crizotinib is not necessarily the modern comparison, but the crizotinib arm cannot negate how well the lorlatinib arm alone is doing. And when you looked at the Kaplan-Meier curves that Dr. Solomon displayed, the lorlatinib curve was almost, you know, straight horizontal. There were hardly any events on that arm going out to 5 years. It was quite amazing to see. So that part does not change regardless of what the comparator arm is. So I think the hazard ratio would be not so impressive, although still quite positive, I think, if I had to bet, if the comparator arm had in fact been, you know, alectinib or brigatinib. But the median PFS would not have been affected by that. And we haven't seen those kind of outcomes from the second generation drugs, alectinib and lorlatinib. So alectinib and brigatinib.
So is this now the new standard? Is this like an approved drug? Is available, or is it in the process of being able? Like, where does it stand now in drug?
It is approved. You know, we have the luxury of five or six ALK drugs approved.
Don't forget ensartinib.
So it is approved. And I think if you look at the NCCN guidelines, they give you the option of choosing among different ALK inhibitors. And I think when the CROWN study was first presented a couple of years ago, and lorlatinib became available as a frontline option, there was still choice. You know, some oncologists, in fact, I think many oncologists preferred to still give patients alectinib because they were familiar with it, and it was, you know, they were familiar with how to manage the side effects. But now I think with this long-term outcome, it's a little bit more difficult to justify choosing anything other than lorlatinib.
And again, this is metastatic disease. So do I need a trial, Balazs, I'm gonna theoretically, I have a stage 3, unresectable, non-metastatic, non-small cell lung cancer that's ALK positive. Do I really need a study to do this, to give patients after chemo RT ALK?
Yeah, that's an outstanding question. And I think that's, you know, looking back at the LAURA study kind of made me say that we can be a little bit more courageous as a field, because many of us did say, well, you know, osimertinib, you know, we're using it for early stage, you know, adjuvant, we're using it for metastatic. It makes no sense not to give it, you know, for post-chemo radiation. Many of us adapted that practice. LAURA proved that, you know, we as a field could predict pretty well. And especially for some of the uncommon, you know, subsets of patients, large studies will just not happen. So I think we need to be willing to make some smart decisions, but that means smart decisions and not just blanket recommendations for everybody with an actual actionable mutation to get the most expensive drug. That has to be a particular setting with significant risk to justify treatment. You know, that has to be a treatment, you know, that can be reasonably well tolerated, and that has to be a treatment that has fair documentation in similar context in a way. So I would think, for example, picking an ALK TKI post-chemo radiation will not be a difficult choice. I'm not sure if I would pick lorlatinib in that context, though. And I might choose alectinib where we have adjuvant data and then definitely a safer drug. But if you're talking about BRAF V600E, starting that conversation is a lot less obvious, because less efficacy, more toxicity. So there, you know, it will be hard to make those very straightforward, you know, decisions. And I look forward to learning what Lecia thinks about this.
Lecia, what are your thoughts?
Yeah, no, I agree completely that just because there's a targeted therapy that's approved for the mutation that the patient has, that doesn't mean that all of these paradigms of adjuvant therapy necessarily apply. It has to be well tolerated. It has to have a high response rate in the metastatic setting. It has to have CNS penetration, because I think that's really the big risk for a lot of these patients with early stage disease, is whether it's actually micrometastatic to the brain. So if you have a drug that doesn't get into the brain at all, I don't know that you're helping them.
Look, you both are the experts. I'm going to wear my patient's hat on. So if I were a patient, it seems to me, I'm looking at the ALK ones. Wasn't there data on ALK that you could use it adjuvantly? And I forgot. And I think if you use adjuvant,
the ALINA study.
And there's a PFS benefit. I don't, right? Well, unless I believe it was a PFS, right? So essentially, you have evidence that you could. If you use it adjuvantly, you have PFS benefit. So it seems to me if you have a locally advanced non-metastatic, there is a benefit, but you're saying you don't know which one you would choose. I guess I'm just wondering, if you have to pick a study for the ALK positive, Lecia, you need to pick a study, the next generation of studies for ALK positive disease patients. Would you put your resources in duplicating the the LAURA trial, for example, for ALK positive, or you would say I probably should take my resources somewhere else because people are going to use it anyway?
Yeah, I wouldn't put my resources into a placebo-controlled trial for ALK patients with unresectable stage 3. I don't know that I would have equipoise randomizing a patient there. Because we do have this discussion about the different ALK inhibitors that are available, I might have equipoise about putting a patient on a trial that looked at consolidation, alectinib versus lorlatinib for ALK patients, but that's, there's probably other scientifically more exciting things too. But I think to establish a standard of care and randomize patients to placebo, I personally don't think we need to do that.
I totally agree. I think duration of therapy is an interesting question, but it will be very difficult to answer in a way. Whether patients in the adjuvant context need or do not need chemotherapy, very, very, very important question, but also very difficult one. So in the cooperative group setting, we've been talking about some of these designs, but they can be very challenging. So hard to commit to long term. We certainly still need better drugs. We spoke about how good lorlatinib is, but lorlatinib could be made better, with less side effects. And there's hope, for those better drugs to come around. And ultimately, we still need kind of combination strategies in many settings. And that's where the EGFR field has kind of exploded just the last year, with new data that actually now suggests that finally 20 years after everybody's stating we need combinations to prevent resistance and extend benefits, suddenly we actually have combinations. Now we just have a hard time figuring out for whom to use it and how to use them.
Okay, next one, Balazs, it's still you. Anything
Well,
more?
the next one, takes us to sort of those combinations, because this ASCO was a big one for Emmy Laser in a way, with 3 presentations, that tell us about different aspects of the amivantamab lazertinib bispecific EGFR-MET antibody plus a 3rd generation EGFR TKI combo. And, one was about, of course, the amivantamab part of the combo, at least a lot of side effects, right? Infusional reactions, very high risk of thromboembolic events, which nobody anticipated in a way. So the sub-Q version, there was some hope, that maybe some of these side effects can be mitigated. And with that, maybe a more convenient and safer upfront combination regimen can be designed. So the PALOMA-3 study beautifully highlighted all those elements: more convenient, less infusion reactions, less thromboembolic events. The PK data looked the same. Progression-free survival looked pretty much the same. And then just the icing on the cake out of the blue, and overall survival benefit with the sub-Q version. So what's not to like about it? So as soon as the sub-Q version will be available, I think we'll generally use it. And with that, I think the conversation frontline is much more relevant. And with that, we've seen the Mariposa study now looking at specific patient characteristics where the combinations seem to be particularly more effective, and those were co-mutation status. Those were ctDNA positivity, patients who do not clear their ctDNA, liver mets, etc. So we're learning about patient and molecular features that can guide us towards combinations. And lastly, and with that I'll start, the Chrysalis study suddenly also showed that this combination works quite well for the atypical or uncommon mutation positive patients, to the point that the benefits seem to be similar to what we see with osimertinib for the common mutation. So again, three, they were not home runs, but they were pretty good hits, by the Emily Azar team, making an impact as to a high level of comfort and broader use of that regimen.
Lecia, what are your thoughts?
Yeah, I agree. I think that regimen was painted in a very good light after this ASCO, and I especially liked the Paloma study looking at the different mechanism of administering instead of IV sub-Q. This is huge for patients, especially in a drug that needs to be given, first weekly, and then, it can go to every other week. But that's a lot of infusions. And the first 2 days, you have to. The infusion reactions are so common with this medicine that the schedule that we plan on is 2 days in a row, because we know the first day they're going to have an infusion reaction. So we already schedule them to come back on the second day. It's just a lot for patients, a lot to go through, depending on the familiarity of your team with these infusion reactions. A lot of patients spend the night in the emergency room. I mean, this is a big deal to start this medicine. So to have it be much safer in a subcutaneous fashion that can be transitioned to, maybe someday at home. I mean, we're giving all kinds of sub-Q injections at home now, right? For diabetes, for weight loss, for psoriasis, for everything that's on the television commercials. We can, maybe we can give some chemotherapy at home sub-Q. It's amazing.
Wow. Okay. Do you want to pick one now, Lecia?
I thought that the ctDNA results from ADAURA were also interesting. So this was our colleague Tom John presented the ADAURA trial, the randomized post-operative osimertinib versus placebo, which is now been shown to have a survival benefit, is our standard of care. What they were looking at now is monitoring for minimal residual disease. And interestingly, there was a way to do it that was, I think, simple and cheap, because all the patients had EGFR. Maybe let's just monitor their EGFR plasma mutation. But this team actually did the more tumor-informed, kind of a specific signature, bespoke assay for each patient. And they did see that assay was able to predict or to alert who was going to have a clinical recurrence 4 to 5 months before it happened. And they were actually asked, I think it was Tony Mock maybe asked from the audience, would it have been just as easy to use an EGFR assay that was much cheaper? And they said no, that they actually looked at that, kind of artificially, retrospectively, and that wouldn't have been nearly as sensitive. So the money for the bespoke assay actually gave them added sensitivity.
So Balazs, for the ctDNA with something like this one using for ADAURA, to me it seems that what I would like to see, and maybe it shows in this trial or future trials, I would like to see that we know that ctDNA positive is going to predict relapse. I don't think that's rocket science anymore. But what I think will be very interesting, if you get ctDNA negative, if you have somebody positive and you are on osimertinib and then they convert to negative, then you're able to stop the osimertinib. You don't need to go for another 2 years. Let's say you convert to negative. Are you guys looking at this where you can probably minimize the duration of therapy based on the ctDNA?
Now that's a great question, and I've heard that brought up a few times, and I'm a little bit doubtful that in that particular context, ctDNA will be that tremendously helpful. But number one, let's just talk about this presentation. I think it was great to see that an assay can be created per patient. The assay definitely shows that if it's positive, poor prognosis. If you detect it, if it predates imaging findings by 5 months, all those are great. But if you think about it, only 8% of the patients were MRD positive in the study, if I remember correctly. Now, if we contrast that with 87% who recurred, right? That tells you that the sensitivity of the assay is
8%?
I mean, in the placebo arm, 80+% of the patients recur, right? So a good MRD assay would pick up a large percentage of those, not even close. So I think the sensitivity of these assays is not where it needs to be. So I think we still need waves of development in a way. But then in terms of how to use it, well, enriching studies for MRD positive, MRD negative, great. I think in terms of using MRD positivity to intensify, potentially. But if you say that you're gonna stop treatment in patients who become ctDNA negative on an adjuvant treatment, well, that's kind of obvious that you're making them ctDNA negative. So I don't think that information will help in terms of duration of treatment. If they are ctDNA positive on adjuvant osimertinib, that means that they are resistant. You see, so that very specific information, I have a hard time kind of digesting why that actually would be the right use of that.
Let me tell you how my simple brain is thinking, and please correct me. I mean, you guys are the experts. I'm assuming that when you do surgery for early stage disease, some patients are going to be ctDNA negative just by virtue of surgery, or is that very naive thinking that everybody is going to still be positive?
Good thinking.
Okay, so I mean, so if you have some folks who are negative, maybe I don't need to treat these folks. I mean, maybe At
the outset, yes, but you said during monitoring to figure out the time of how long to continue. You follow? That's a different question.
I see.
Like 6 months into treatment, you check ctDNA, they are negative, so you can stop. That's a false lead.
I see what you're saying.
You follow, but at the outset, sure, they should be negative if the surgery was done well and the biology is not such that the patient has micrometastatic disease. But we just learned from Lecia that the biology of EGFR-mutated disease is that of micrometastatic disease, which these studies show you because 80% plus of the patients recur in 2 years. So they had micrometastatic disease that we didn't pick up on imaging, and now we just learned we didn't pick it up on MRD testing either.
So what they do in CML is when they have patients on these very effective TKIs for many years, they do little trials off of the medicine to see, okay, do I get a recurrence of my MRD signal? If yes, I got to go right back on the treatment, but I can gingerly take it off and see what happens. So if we had a more sensitive assay, and I agree, Balazs, we're not quite there yet, but we're getting there. We can think about maybe doing some, transient breaks from treatment to monitor and then put the treatment back on if we need to.
I mean, the fear is always that I think there's very little predictability how patients recur. I always think in a disease like lung cancer or bladder cancer or pancreas cancer, if because you don't know whether at the time of recurrence things will just go crazy, that's why we're afraid. It's very different than low-grade lymphoma or something like CLL, where the recurrence is unlikely to be widespread crazy disease.
Yeah, but I echo what Lecia just said, and I know Boston City traffic, so I know that Lecia, you want to take your foot off the brakes all the time because you're just bumper to bumper. I mean, we might be overtreating a cluster of patients, that's for sure, especially no negative patients.
We always do. In adjuvant therapy, we always do.
Yeah. So like the stage 1Bs, I think a large majority of them we're overtreating. So maybe there will be a population of patients where, yes, indeed, we can come up with some smart ways of figuring it out. But the best might be at the outset, kind of, if you have a really good MRD assay, if there's a stage 1B patient who's MRD positive, suddenly, that could make the call as to, it's worth it to commit to many, many years of adjuvant therapy.
Anything else that happened at ASCO? I think I feel bad for ESMO 2024. I'm not sure they're going to have anything.
We should maybe talk about Crystal before we leave.
Crystal, I'm just writing the names, you people. Crystal with a C or with a K?
K.
Okay, let's talk about Crystal. Okay, go ahead.
K for KRAS. So the Crystal 12 was a phase 3 study of second-line adagrasib versus docetaxel in patients with a KRAS G12C mutation. And So this was a randomized second-line trial. Patients were previously treated with platinum and immunotherapy, platinum-based chemo and immune therapy, and it was randomized against docetaxel, the forever standard second-line treatment that none of us really give in the real world, but all studies have to be randomized against the 75 milligrams at least.
So why is that though? I mean, you both obviously are heavily involved in a lot of this. Like, why can't we? Is docetaxel always going to be the control arm for the second line therapy? Is that like a regulatory stuff from the FDA, or what's the deal?
I think so. I mean, I don't mean to say that I never give the medicine. I never give it in the way that it is in these trials of 75 milligrams every 3 weeks. It's really a high dose, I give it in a lower weekly dose in the real world. But the studies always have the high dose.
But is it the proper control in second line?
For now, sadly, yes. That's just the reality that we haven't made enough progress. Yes, indeed, there was a slight benefit adding ramucirumab, but not enough to make it the regulatory standard. It cannot be used in some patients. And since that time, we've seen failure after failure. And, Crystal 12 is not necessarily a failure, but also not a big win. And then you have the EVOKE study, with the anti-TROP2 ADC, which seemed to be a big failure. So yes, indeed, we haven't shifted the field in dramatic ways. But Crystal 12 seemed to maybe just a tiny bit better than CodeBreak in terms of outcomes. We didn't see the overall survival results though. So until we see that, we're staying in a limbo as to is it truly impactful? But at least it offers, an oral choice that most patients prefer and allows sequencing. So we have at least 3 lines of treatment to offer to our patients. So it is still a significant advance, but not as much of a breakthrough as we would have liked.
So it's better than docetaxel, but
well, from a certain angle, yes, higher response rate, more convenient, somewhat better adverse event profile, different adverse event profile, and PFS benefit, yes.
So Lecia, we've talked about LAURA, ADRIATIC, CROWN, Mariposa, Paloma. We mentioned Pacific in passing. We mentioned Alina in passing. We talked about Crystal. All you guys definitely take the crown for all of these names for sure. Did we miss anything that listeners must know? I mean, I know there are thousands of abstracts, but these appear to be the practice changing. Anything we may have missed, and it has to have a good name.
So now we would need to be talking about my margaritas and
That's your next study. I know we're taping on Friday evening.
The rest of ASCO I spent at parties.
So. Okay, I got the message.
I think it's outside of the range of this conversation, but there was a nice study about screening in Taiwan, an update on the national program. And so the national screening program that they're doing, which is population-wide in Taiwan. So I think in the future, on future editions of your podcast and at future ASCOs, we need to talk more about lung cancer screening.
You're right. There was a good study. I had extra margarita for that one.
Actually, a couple of years ago, I had you and Sharu, and remember we talked about low-dose ctDNA and CT scans, and I thought it was great. But I would love, in a future podcast, I would love to have you talking about early detection with liquid and multi-cancer early detection. I believe it's on the radar. It's something that you probably all are interested in. And I think it's a fascinating field because for patients, they hear about this, and I actually, know of a couple of people who would just call me and say, hey, I did this and it says it's negative. What do I do? Like, I don't know, just like, it's like, I'm going to do it next year again. It's like, there's so much confusion out there. And I would really be curious your thoughts. So, Lecia,
next time
we'll do this. I can't be thankful enough. Thank you so much. I know this Friday evening, Friday afternoon, we'll air this in about a couple of weeks. And believe me, if I tell you, it's going to serve a lot of people who are listening very well. And hey, now they know that they should not watch EuroCup. Dr. Sequist and Halmos, thank you so much for coming on Healthcare Unfiltered.